So my name's Ben Hartnell. Today's period of instruction is going to be over chest trauma. So first we're going to review kind of the skeletal injuries that can happen, and with that comes the anatomy of the thoracic cavity itself, looking at first skeleton. We have primarily going to be our ribs, along with our clavicles, scapula, and spinal cord. Ribs are set up as far as kind of structure and subdivided into true ribs, false ribs, and then the very bottom two pairs are floating ribs as they have no cartilage. All the false ribs have they don't connect directly to the manubrium. So set 12, 11 are loading ribs. Set 10, 9, 8, 7, 6 are going to be all false ribs. Where that comes in is you can see where there's a multiple connections prior to them getting into or attaching to the sternum. Sternum itself is made up of the xiphoid process on the bottom of the manubrium, and then up top it's going to be the jugular notch, and also known as the angle of Louis. We have our clavicles here, attach up to our acromion process, and the shoulder joint on the back side we have our scapula, and then we have our thoracic spine, top part of our cervical vertebrae, and the bottom part of our lumbar vertebrae. Clavicle fractures are pretty common. They account for, as you can see, 5% of all fractures. One of the most frequently fractured bones in children. When they are fractured, they stick out pretty. They're relatively obvious. One of my buddies, when we grew up, we were out riding dirt bikes. Went over jump, came back up, and it looked like he had an extra trap. It was so extremely high up there. It was pretty obvious. You can see in this picture right here. There's a little bit of danger, a possibility of some of those bone shards going into the thoracic cavity, but overall, there's still that space between this clavicle and the rib cage in our inner kind of thoracic cavity area. The clavicle is also relatively fractured just because of its location and its overall instability. There's not a lot of extra support in that area. It provides a little bit of stability to the other ones. It's kind of floating out there by itself. Next, we're going to talk about rib fractures. If any of you guys have had them, it makes everything hurt. Breathing, laughing was the worst. Even just taking deep breaths is extremely painful. So sometimes many people with fractured ribs will be taking very shallow breaths just because they don't want to breathe deeper and have to cause more pain for themselves. So we can have some hypoventilation when this happens. Um, it most often occurs on the lateral aspect of the third through eighth ribs, a little bit further down, right? Those ribs that don't have, some of those are kind of some of those true ribs, but many of those are in the false ribs area. They don't have quite as much support. We can see here on this picture to our left, if we look at this chest x-rays, we kind of go down, we see a slight little partial deviation over here. It looks like the beginning of a pneumo. We have this big old clear area that doesn't look like there's any infiltration. Basically, this is actually a really clear x-ray versus on this side where we can kind of see that extra little slight cloudiness, not even necessarily cloudiness, but it looks like there's a little bit more there, and that's lung tissue. On here, it looks like there's a little bit less, and we can see those fractured ribs right there. It actually looks like disconnected or fractured or dislocated up by the sternum, and then also down here on the back side. So that is almost a full floating rib segment on that full side, which would also be known as flail chest, which we'll be talking about next. Um, Usually, but the rib fractures in general are not very life-threatening, although painful. True danger, though, is if there's a fractured rib that penetrates or causes a pneumothorax, hemothorax, or hits any of our good organs, the pleural cavity, lung, liver, spleen, anything like that. Not sure how well some of these videos play on the recording in class. We'll take a look at this better, but here's just some examples over to the right of a flail chest kind of happening. Basically what happens is when two or more adjacent ribs are fractured in two or more places. What this does is provide a floating segment of rib that it moves in a paradoxical motion in the sense that as the chest wall goes out, floating segment gets pulled in, and when the chest kind of comes back in, the floating segment kind of stays out. Some parts of this video are a little bit harder to see for the if you're trying to watch this, but on some of these videos it's a little bit more clear, and you can see that very blatant movement that is contralateral to what is the rest of the chest, or paradoxical. Mortality rate is 8 to 35% because of the underlying issues. Usually it takes a lot of force to cause this big of a fracture. And there's a lot of underlying associated injuries with it. What you'll see is a bruising, tenderness, and bony crepitus on palpitation, as well as the paradoxical motion, which tends to happen a little bit later. But basically, as we take a deep breath in and try and create and have our chest expand to create more space, that negative pressure in interthoracically then pulls in that piece of that little island of floating ribs, and then when we try and we breathe out, our diaphragm moves up and creates a higher pressure. We try and the rib just kind of moves in the opposite direction. So those segments interesting, a little bit challenging to deal with. The best way to treat this one, if we can add, they always say some bulky dressings, good luck. If you can try and get some bandages there to move with it, maybe. We used to do sandbags. Sandbags are not used anymore. What we'll use now these days, one of the best ones that helps is positive pressure. By us always pushing out our positive pressure ventilation, by us such as CPAP or BVM, when we add that, then instead of having that negative pressure during the intake of our breath and that that paradoxical movement of that floating island of ribs, instead we push out and the whole rib cage moves as one, just because we're not using negative pressure to breathe. Next, the sternofracture. It's associated with an unstable chest wall, myocardial injury, and cardiac tamponade. It is so many of them can be associated with many of these following injuries can be associated with sternal injury. Pulmonary contusion, if it's enough to fracture our sternum is relatively sturdy for the size of it, the thickness of it. So you can get that bruising of the lung tissue. You can have associated rib fractures. A pneumo or hemothorax is relatively likely. A thoracic line or spine or scapular fractures. Then a pneumomediastinum. Pneumomediastinum is where air gathers inside the mediastinum, so that middle part underneath our sternum. The mediastinum is kind of where our heart is. It's outside of the normal pleural cavity, which is where our lungs go. And this is actually here. This X-rays, the contrast looks to be flipped, so possibly. And this looks, oh, never mind. The contrast is the same, but it's a little bit different. Or this might be MRI. We see this air up here. This is typically a pneumomediastinum with a fractured sternum in two separate places. Three, if you count down here, it looks like he had quite the chest trauma or this person had quite the chest trauma causing this, and so they're going to have a lot of underlying issues going on. It doesn't look like there's too much filling in the pericardial sac. Mediastinal hematoma is just bleeding into the mediastinum. And then we can also have aortic or great vessel injury, since when we get a little bit more into the vessels that can all be injured, we have our subclavicular arteries and veins, our aorta, our superior and inferior vena cava, jugular, and carotids as well. So there's a lot in that area, as well as our pulmonary artery and veins is one of our most large vessel heavy places in our body. Pulmonary contusion, which is that hematoma, bruising in the lungs. Many times it can come kind of from that stretching and shearing of alveoli. We'll have intravascular structures as the overall structures. Remember that the alveoli are kind of like grapes at the end of the bronchioles, and so because they have a little bit different inertia, alveoli more filled with air, a little bit more mass along the bronchioles. As we have this sudden deacceleration those move at different speeds, and you can cause this shearing effect. Much more concerning with if it's enough to cause crazy damage to with the acceleration is obviously our aorta, which we'll go over here in a bit, or even our vena cava. But signs and symptoms that they can kind of have in it. Uh, One, they're kind of subtle at first and worsen over 24 hours, so that kind of bleeding and difficulty breathing increases. They're going to have tachypnea and tachycardia. They're going to have a cough, hemoptysis, which is the coughing up of blood, dyspnea, shortness of breath, crackles as that bleeding gets into the alveoli. It'll have the sound of Rice Krispies, kind of that popping sound, crackling rails when they're attempting to, or as they're breathing, just because that blood from the hematoma itself is filling up the alveoli sacs. Evidence of blunt chest trauma, hopefully that's a little bit obvious, but it always helps. And then cyanosis, because they're not able to move enough air and oxygen. All right, we're going to start out now with our pneumothoraxes. Our first one's going to be simple pneumothorax. Pneumothorax in general are not always trauma-induced. Sometimes people can have a spontaneous pneumothorax, particularly white, skinny, tall people. You can also have it from other medical procedures, or such as overventilation. We can also, and then trauma is a big one, whether it's from a internal issue, that bleb in the lung tissue that starts expanding and something happens enough where air starts escaping from the lungs, or more from an open thorax, pneumothorax, which we'll talk about in a moment, or a second chest wound. With simple pneumothorax, typically doesn't usually always need to be treated heavily. Most of the time, if anything, just some oxygen increasing and high flow oxygen. They have signs of a simple thorax. Positive pressure is not the answer, because unless we absolutely need to get a tube, because positive pressure and PEEP, even PEEP, will cause it'll cause the simple pneumo to get worse and eventually develop into a tension pneumo. And we had a lot of positive pressure, it happens rather rapidly. So if they have signs and we have to tube them, just be ready to dart them or dart them. Signs and symptoms are basically, we can look on here on this chest x-ray, start from the top. We really don't see, right here is our trachea, this kind of dark line coming down. It's slightly over here, but it's kind of the way that shifts over. On this side, we see the lung tissue all the way filled up, and on this side, we got this little bit clearer area where we're looking at the edge of the lung tissue as it's getting pushed over a little bit. At this time, the heart is still pretty midline. We have a barely little hump of our right ventricle on this side, our big left side of the ventricle is right where it should be. We have this nice, pretty arch of our diaphragm and underlying organs such as the liver and the liver, spleen over here in the stomach. So, beginning of simple pneumo, nothing too crazy on this one. We can look at a patient can complain of chest pain, dyspnea, tachypnea. They can have the severity of a simple pneumo kind of depends on how far this lung has been pushed. The more the air it fills in there, the more this lung is going to collapse. When it starts collapsing and starts shifting and having an effect on our major vessels and our overall dyspnea is when we're really going to start talking about a tension pneumo. And basically that's just kind of, they're going to have tachypnea, dyspnea, chest pain, and the worse it gets, the more that lung is being collapsed. Open pneumothorax, also known as a communicating thorax, as in air is communicating from the outside to the inside and not via the mouth and trachea. As we can see here, this is a pretty obvious one and a pretty brutal one. Looks like a possible GSW, with a pretty good exit wound. Here's another one, and it always shows the importance of rolling our patients over, because we can miss these. There's going to probably be a pretty good chance most of you guys will end up missing a small wound on the back at some point in your career because you didn't roll over, and you're wondering why they're desetting. Almost missed quite a few of those. Luckily, if you can roll them over, you'll notice it, throw occlusive dressing on, and we're bueno. What happens there? This is particularly obvious in penetrating trauma, but we're exposing the pleural space to atmospheric pressure. Severity of the injury is directly proportional to the size of the wound. Somewhat, I would say. The more air that gets in that wound, a smaller one can still develop a tension relatively easily if enough air gets in there. Next, we're going to, and as that accumulation of air starts building up, what can happen as well, and I think on here it mentions, is that it starts to act like a one-way valve depending on the size of the hole. That's why those smaller holes can sometimes cause a tension quicker than a big giant open one. Because some such as this, as air gets sucked in when we take a deep breath, because we have that negative pressure within our chest, it gets sucked in, and then as we go out, those tissues get pushed up and can provide kind of a seal against there. So all we're doing is increasing air into a pleural cavity without allowing it to escape. A big hole like this, it's going to escape. That lung is not getting much use, but it's getting a little bit, and it's still not pushing air in. Remember, fluid does not compress, air does. So as more and more air gets in there, it starts developing that pressure, and that pressure is going to start shifting those organs, which is going to lead us to our next one. Um, and anytime we have that medial sinual shift can lead to the reduced preload. The reduction of preload will reduce our cardiac output. If we don't get no fluid into the pump, we ain't gonna get no fluid out of the pump. So we have two pictures on this one, and we're gonna start talking about the tension demo. I've brought this up several times in class, but this is one of the coolest life-saving we are heroes type procedures that we do. You can instantly fix someone from a near death or even in a code. This is a reversible cause and bring someone back to life as long as you do the rest of the stuff correctly. But then you dart them and watch all of a sudden everything else get fixed if this was the only thing happening. And it is a pretty cool thing to see. So on this picture, we can go down. We don't really see great trachea, but we can kind of see here the left side looks to be relatively full. This the patient's left. Now our right side right here, we can see this line. That is pretty obvious that we see the lung to start to collapse. This is still considered a simple pneumo. The left ventricle of the heart right here is kind of where it needs to be roughly. There's a decent little arch here for diaphragm, and the right side of the heart isn't getting pushed out too far. Overall, the mediastinum is still pretty central overall. We can see maybe a slight shift starting to happen down here at the bottom, but nothing too crazy. Picture on the right, different story. This is a pretty extreme example, but this is one where you might even see possibly some tracheal tugging or even, dare I say, tracheal deviation. We can see as we go down, here's our trachea. Oh, it's shifting all the way into about mid-clavicular nipple line of this patient. Look how far right that is on the patient's right, our left. Look what else is in the right side of the chest. We have the entire heart. The left ventricle looks to be pushed over past the spinal column. Look on this side, that is normally way over here. So everything is getting pushed. That vena cava, because it has very little pressure holding it open, the CVP of the central venous pressure around the vena cava, where the inferior and superior vena cava kind of meet up prior to go, right as it get ready to go in the right atria, it's usually anywhere from like 1 to 4. It is easily compressed. Aorta has a bit more pressure to withstand some of these, but this air in here will collapse that vena cava, and then we'll collapse our aorta. Will start to get pressed down too because it has no fluid holding open. Because once we take away that blood going into the heart, no blood's getting out of the heart, and not to mention our pulmonary arteries and veins are just squeezed shut as well. We don't see any overlying fractures, but we can also look at this underlying diaphragm right here and look how flat it is compared to this nice over here. It's kind of hard to tell on this side, but usually there's a little bit more curve here. It's flattened, it's pushed. The entire mediastinum, and to include the left lung tissue, has to be like right here, compressed all the way over. Tension pneumo. When we dart this patient, you most likely might hear a gush of air out of this one. We're going to go ahead and find our dart, go down between our second and third intercostal, ribs for our third intercostal space. So our first one, that first rib's kind of hidden right under here. Second rib, third rib. And so gonna dart there. For our mid-axillary, which work just fine on this patient, it's gonna be it's gonna be either our fourth or fifth intercostal space, and we're just gonna come right into right about there. And try and fix this patient up. Once that pressure gets released out of there, you're just going to see that the lung be able to reinflate and really help. We might still have to add some help and some positive pressure with that, but shouldn't be too difficult. All right, so when we get that signs and symptoms to look for, we're going to have increasing dyspnea, difficulty ventilating with a bag valve mask. In fact, if we start ventilating with you're going to feel a ton of resistance. And if we start ventilating with this bag valve mask, you're going to notice a ton of, it's going to worsen and the vitals are going to get worse. Doesn't mean we stop ventilating with that, it just means we need to dart the patient. That unilateral decreased or absent breath sounds, tracheal deviation, real late sign typically. Many times it's only found post-mortem, but on that one patient, it was almost deviating quite. But tensions can happen a little bit before it gets to that bad. Hypotension are signs of unexplained shock. If we have chest trauma with signs of unexplained shock and just dart the patient, if we can't tell which side is possibly, we dart both. Diminished or absent breath sounds on the lungs on the injured side. If it's pretty obvious what side the injured side is, that's the side we're going to dart to. If you can tell that there's a little bit of tracheal tugging, the tracheal tugging is going to the healthy lung, and we dart the other side away from the tracheal tugging. Distended neck veins, because there's so much pressure building up in the chest, blood flow is not coming back down into the thoracic cavity, and so we're going to start building up that jugular vein distension, or JVD. Unequal expansion of the chest, a little bit more obvious in peds, but it's still pretty obvious in adults. You can get hyperresonance on percussion. Typically, we're not needing this to confirm that we have it, but we can also have that subcutaneous emphysema where air gets in the subcutaneous space. Relative can be a bit of an issue, but nothing. Many times we're going to see that subcutaneous emphysema more in line with tracheal transection or disruption, and that's just air escaping from there. However, we can still find it on intention as well. This isn't what we're looking for with our jugular vein distension or JVD. It's when that jugular veins are distended, bulging, increasing right atrial pressure. This can occur from heart failure, fluid overload, or even pulmonary emblems, or attention pneumo. To test, we raise head of bed 30 to 40 degrees laying flat. You most likely will see, everyone will see some type of JVD. If it's noted, then they have increased jugular vein pressure. If it isn't a tension, they'll probably have increased CVP, but because the tension is dumping their CVP, you're not going to see that on it. We don't have a way to measure it anyway, so it's fine. But if they had a Swan scans, they could. Other pulmonary injuries. So if we have an open pneumothorax or sucking chest wound, and we decide and we throw on occlusive dressing on, and we dart our patient, or so we have that on. First thing we're going to do is kind of lift up that corner and try and dart our patient. If that works, great. If it doesn't, no air is coming out, then we dart them. Even though they already have a hole in the chest, we're not going to make anything worse. Sometimes we're not, because the tissue itself blocks it, we're just going to go ahead and create a new hole for us. As far as we've gone over this lab in class, and this skill all the way from pediatrics to adults, the best thing is thoracic decompression. You might see flight crews or the hospital do something called a finger thoracotomy, which is usually right here, and instead of just sticking a needle in, they'll basically use a scalpel, much kind of like a surgical crike, and they'll make an incision and open it up a little bit, and it allows that air out. Works relatively well. It works a bit better than darting, and it's a bit more secure. And then what we do after that is throw a chest tube over there. Not going to really teach you guys that now until it becomes more widespread throughout more places, but I wouldn't be surprised in a few years if it's a bit more common practice to do that way. All right, hemothorax. Big difference between hemothorax and pneumothorax. Hemothorax isn't an issue with, they might have a low blood pressure, but that is due to the lack of blood in the circulatory system because it's filling in their chest. UMC does super interesting things. Is they'll drain the blood from the thoracic cavity, so long as there's no other complications. They'll filter it and retransfuse it into their body. We obviously don't do that, but it's pretty cool. And look over here, relatively obvious. It looks like they actually have a bit of a hemopneumo because it looks a little bit more clear up here. Could be wrong. We're not really worried about that letting the blood out. In fact, it's fine if we keep it in there, and if bring them to UMC, or Sunrise might do it as well. They can keep that there. It's the bigger issue is that we can fit basically our entire blood volume, or all all of it in a practical manner, inside our thoracic cavity. So one of the biggest things between a tension and a pneumothorax, if between just the two, a tension pneumothorax and a hemothorax will be the pneumothorax causes JVD, where the hemothorax causes flattened neck veins. Those flattened neck veins are just due to there being no circulatory volume. Here, you do see a slight kind of shift over, but that's just because it's pushing over. Overall, the heart's not moved very far over to this side, and really the only reason that they don't have a huge amount of a very good blood pressure, if this patient had low blood pressure, is because they have no blood in their vessels. So some things, diminished or decreased breath sounds. I guess you could hear dull resonance. You'll have hypovolemic shock, hemorrhagic shock symptoms, narrow pulse pressure, and tracheal deviation, kind of occasionally, I guess. Next is going to be traumatic asphyxiation. This is where something large was put on the chest, causing a increased interthoracic pressure, but down, and it's pushing and it's causing an increased pressure of everything is pretty much superior. We see this line of demarcation right around here, where you have this purple bruising like skin sign on the above the injury, and then we'll see this petechiae in their eyes, this bleeding. It's not just like bloodshot eyes. It is looks, as we can kind of see here, it looks like completely blown vessels as opposed to sort of bloodshot eyes. This that purple discoloration of the face and neck, bruising around the eyes, and then that subconjunctival petechiae, and it's just from all that pressure getting pushed up and causing blood vessels to burst due to the increase and the huge amount of pressure that is on their chest. There's not a ton we can do about that. Supportive care, positive pressure ventilations if we need to. Make sure if there's any pneumo that developed, treat that, but supportive care, fluid, and transport. Next, we're going to go over heart and great vessel injuries. They can result from either blunt or penetrating. Our great vessels include the aorta, the pulmonary artery and vein, superior and inferior vena cava, as well as your subclavians kind of count in that area as well. They're used to access central lines. They don't really have valves in them. Our IJs, as they kind of intersect with our aortic arch and into the vena cava, I'll kind of count that depending on arteries or vessels, or veins. Complications, life-threatening arrhythmias if it's right to the heart. We'll talk a little bit more about that here in a moment. Conduction abnormality is kind of the same. Congestive heart failure, it causes so much damage to the heart itself that they start having CHF-like symptoms. Next, we'll also have, they can be in signs of cardiogenic shock because their heart's not working well. Cardiac tamponade, which we can't do much about. A long time ago, we used to have something called, we were able to actually do pericardial tamponades. We don't anymore. Being said, we used to do that. They can have the cardiac rupture, usually not very survivable, but possibly, who knows. And then coronary artery occlusion. So myocardial contusion, just the bruising and contusion of the myocardium itself, so the muscle of the heart. Chest wall strikes a dashboard or steering column, causing blunt-like force to the heart is an example of one of those. Similar to patients with the myocardial infractions, you can even see ST elevation and similar on there. We're going to go ahead and give oxygen, ECG monitor all these patients. If they have a strike to the chest wall injury, particularly relatively decent, either penetrating or blunt, we need to go ahead and throw them on at least on a 4-lead, probably a 12-lead, just to check. They might need pharmacological therapy for some dysrhythmias that can happen, or presses for hypotension, much like a cardiogenic shock, because now we're having a pump failure. So myocardial contusion, again, this is kind of what happened to that football player a year or two back, or at least that's what they assume. Strikes there, and it just happens to strike right during the upstroke of the T wave, and we get that basically the partial repolarization of the cardiac tissue, which causes the heart to, or go into VFib because some of the tissues repolarize, some of it is not depolarized, but repolarized. And so what'll happen is those cells that are partially repolarized now start acting on uh, they'll activate, and then they'll cause basically the heart to go in VFib because there's no organized activity. We can see this a lot in hockey pucks hitting them, hard cold piece of rubber flying across the ice, striking someone just right, hits them in the chest. Lacrosse balls very hard, heavy as well. Baseballs, you see this probably more than any others. A fist or elbow could do this, and this is where and this that kind of goes back to that pericardial thump that we used to be in ACLS. They still mention it ACLS, but when I first got mine, my first ACLS back 2010-ish time frame, uh, pericardial thump is still part of it. And if you strike the heart with enough force, it causes it causes about 30-ish joules or so, and it can actually restart the heart, much the way that something such as a cardioversion can. So, see that, or a football helmet is seen previously. Pretty interesting. This is more of the myocardial contusion itself, where you can show ST elevation due to a delay in conduction, just because we're having that contusion around whatever area this is. So we're looking at a bit of a anterior septal strike causing a contusion in that area and a slowing of conduction. Next, we'll talk about a pericardial tamponade. We can see it over here when we look at our X-ray, come down, we see this is not the fantasticest of X-rays as far as clarity, but still kind of see over here. Hard to tell if they're as far as air goes, but we can see the issue here. We come down here, we know our spinal cord's there, trachea goes on the right, overall ribs look pretty decent. We get down to the heart. Right here, so we can see the myocardium itself, but then we can see the pericardial sac filled with fluid. And this area right here is the area that they're going to drain with a pericardial centesis. Basically, they stick a big needle in at a good like 45-degree angle just under the ribs. They'll keep advancing the needle until all of a sudden they strike the myocardial tissue. The patient needs to be on a cardiac monitor because you know you're in the right spot when the patient goes into V-tach. At that point, you draw out your needle just slightly, and then you start drawing out of blood of this and fluid that's surrounding the heart in a syringe, and you fix it. Really, not a super hard skill itself, but the whole causing patients' heart to go into V-tach can be seen as an issue sometimes, and we can cause more issues many times. However, how we treat this in the field, we just need fluid. If we can try and increase that preload, we can try and cause this cellular infect to kind of go into effect. The more fluid that we go in, the more that myocardial tissue and muscle expands, allowing a better contraction back and allow a little bit more force to go out to try and get more fluid out. That's not definitive. That is a bridge until they can get a pericardial centesis. Signs and symptoms: tachycardia, respiratory distress, cyanosis of the neck, head, neck, and upper extremities. We'll have JVD. So the following is known as Beck's triad. It is indicating that the patient has a pericardial tamponade, and it's going to be narrowing pulse pressure. Because the heart can't expand as much, the difference between the diastolic and the systolic, because the heart can't pump very much and it's getting compressed and compressed, is going to get narrower and narrower and narrower till eventually they're the same, and then eventually it'll be zero if we don't fix this. JVD, because we have that backflow of blood, and muffled heart tones because the heart itself is surrounded by fluid. So get that dull resonant sound type there around the heart. Myocardial rupture. Pretty sure this picture over to our right is post-mortem. Could be wrong though. Blood-filled chambers, the ventricles are compressed with enough force to rupture the chamber wall, septum, or valve. Causes: MVCs, complications of myocardial contusions, displacement of blood after abdominal trauma, and compression of the heart or laceration from a rib or sternal fracture. Pretty wicked right there. Well, pretty gruesome, big injury. All right, next we're going over our traumatic aortic ruptures. Results from shearing forces that develop between tissues that deaccelerate at different rates. Once again, when you talk about shearing injuries, it's typically, although we brought up a lung bruising earlier on this, when we're talking about on most test questions, whether it's National Registry, if you ever go CCT or FPC, this is a huge one that they always go. anything like that, when we talk about a shearing force, it almost always is trying to push you towards the carotid, or sorry, the aortic. Sometimes the carotid set, but because they're held, that rapid acceleration, that sudden stop at the end, our heart wants to move forward than the aorta does. They're held on by different tendons and ligaments. As that moves forward, the heart and the aorta basically separate in one way or another. Um, Here's a couple different classifications of a aortic injury. These we can see the aorta has a lot of that muscle, which is why it doesn't get compressed nearly as much as the vena cava. But the grade 1 is just that internal tear. Blood flow, because the aorta is under such pressure, can start filling up in some of this area. Grade 2, that hematoma starts building in the media. Grade 3, it's on both sides, it's almost aneurysm, and then the rupture is where it actually bursts out. Usually, if you have an aortic rupture, they don't have very long to live. Being said, it could be a very small rupture and they have a low blood pressure, we're good, which is why that low blood pressure is actually how we're very happy with that. In fact, we give a beta blocker for a AAA and CCT. We typically give esmolol as the preferred because it's short acting, and we try and keep their blood pressure in the 80s, their heart rate low and slow, not super bradycardic, otherwise we're going to start having perfusion problems overall. But we're just barely keeping that map where it's perfusing everything, and that is fine because we don't want high pressures with this patient. High pressures will cause this aorta to burst, and then we have a whole lot more issues, as in they will have no blood pressure. So it's kind of what we're working with. Here's so we'll continue talking about some of these. Advise medical direction of the possible suspected rupture, whether this is in the abdomen or the chest. Even though we're talking about chest, anytime we notice that AAA type issues, we're going to be concerned. Administer high flow oxygen. Whatever blood is flowing, we want it full of O2. Provide ventilatory support with spinal precautions as best we can, because if it's enough to cause injury to the aorta, there's a decent chance there's a chance that it also caused disruption to the spine. Establish vascular access. Ensure rapid transport for surgical repair. When I say this, I tell my partner, I want you to drive code 3 as slow as possible, as slow and smooth as you feel safe. Avoid roads that have a lot of bumps or sudden traffic. You're gonna go, but you don't want to cause the aneurysm to rupture. We want to be nice, slow, and smooth. We want to get through lights and get to where we're going quickly, because unless they're on the surgical table and it ruptures, and even then they might not be able to fix it in time, this patient's going to die. You can pull up into a parking lot, still be in the back of the ambulance, it can rupture, and there's nothing they can do about it. If they're on the surgical table, there's a chance, as small as it is. Penetrating wounds to great vessels. All right. They usually involve the chest, abdomen, or neck, as one would expose. Here's a pretty good picture as we look over here. But they're also accompanied typically by massive hemothorax. Filling that thoracic cavity usually comes from either the heart or the great vessels. Typically the great vessels. Cardiac tamponade if it hits the heart. And enlarging hematomas that can cause compression of the vena cava, trachea, esophagus, great vessels, and heart. So any of these vessels, they bleed, gonna be a bad day. Here's our subclavian arteries and veins. And then as the carotids, all this is pretty much considered our thoracic great vessels, and we can see all of the great vessels centralized in this area, as one would imagine. Esophageal and tracheal bronchial injuries. Most often are caused by some type of penetrating trauma. Can be some blunt, depending, could throat chop. A tension pneumothorax that does not improve after needle decompression. Starting to think of that, particularly air continues to go in with every breath that they get or we give. The presence of continuous flow of air from the needle after decompression, and what we do, providing airway, ventilatory, and circulatory support. We might have to, so long as the tube's going in the right spot, go deeper than if it's just a tracheal injury, like disruption, and go past that, so we're not building up subcutaneous air. If we start noticing an increase in that subcutaneous emphysema, we need to go ahead and we might need to get that tube a little bit deeper, kind of deal with it as we go, and ensuring rapid transport. Yep, let's get them there quick, fast, and in a hurry. Needle crike might work, might not. Surgical crike might be a bit more definitive, but that doesn't help us here. This is an example of subcutaneous emphysema. If we'll definitely see in class. I'm not sure if some of these are coming over in the video. And we can just see that Rice Krispie type refilling of the subcutaneous space. There should not be air in there. So diaphragmatic rupture, I probably have just talked about this earlier when I talk about it. Neo, what happens, and this is a pretty obvious picture over here, but it's a sudden compression of the what can cause this is a sudden compression of the abdomen, results in a sharp pressure increase in inner abdominal pressure, causing the diaphragm to rupture, and basically the organs then end up in the thoracic cavity. Not a great day for everyone involved, particularly the patient. Signs and symptoms: abdominal pain, shortness of breath, decreased breath sounds, bowel sounds or stomach sounds when we go to bag them in the chest. It's not fantastic all around. And the pressure, what we do here is we intubate this patient immediately. If we bag this patient, there's a pretty decent chance, unless the esophagus is also ruptured, even then we're just pushing air into the pleural cavity or different space in there. We need to not fill up the stomach more, but fill up the lungs with positive pressure. That's going to be our best bet. The only answer is intubation or crike. Those are the two answers that we can do here. So work on that. And I do go deeper in this on the neo side. It's the same injury that we'll see there. We can see this is your stomach. It's not supposed to be in your thoracic cavity, in case anyone wasn't paying attention to the x-rays earlier. This is actually, I believe, a slice of a CT. This is a diaphragmatic rupture, and this is, we can see the stomach right here. So with this chest x-ray, we can see the stomach starting to move up in here, and we can see that if we continue to bag this patient and move air into their abdomen or in their stomach, it's going to continue to push the lungs away, and we're going to have this person also looking to have a pneumo on this side, and the lungs getting pushed over a little bit. We can follow the trachea down and see everything, but I think that's what this is trying to show. The lung is being pushed over here, and the tracheal, you're actually having tracheal deviate. Well, this one we wouldn't even notice this, but there is tracheal tugging, but only noticeable in the x-ray, and we see it shifted more over here to the patient's right. All right, that's it for chest trauma, guys. If you have any further questions, let me know. We'll be going over stuff in class. Just got a new microphone, so let me know how all this sounds. Hope you guys have a great day.